So we designed a study in which we took treatment-experienced patients who needed new regimens, and we offered them multiple different regimens that they could take based on their resistance testing and antiretroviral history. We also recommended NRTI combinations that we thought would be effective. And then the subjects chose the regimen and the NRTI option that they would take during the study. We then randomized them to actually taking the NRTI combination with their new study medications or not taking the NRTI combination. And the reason we did this study is because in the clinics, all the clinicians now are continuing the NRTI class of medications even for treatment-experienced patients who may already have resistance to those NRTIs. And so, because we have new medications that we can put together, we thought they were active enough without the NRTIs. And so what we showed was that not including those NRTIs was similarly effective as including them. So we concluded that you don't need to include the NRTI combinations when there are new active medications on board. It depends on what the patient's overall background regimen consists of and how active that looks. So we call it recycling the nucleosides. You know, that we've been using the nucleosides for so many years, they've been so effective for our patients. But with this new study result, we don't need to recycle the nucleosides, which may not have full activity. So we can construct new regimens with full activity, and we don't need to hang on to this older class of medications that we've grown to be very comfortable with, but add pill burden, add toxicity, add cost. And so if we can, so what we showed, we don't need them, and we can eliminate some of those side effects.
So, Karen, one additional issue about the carryover of using nucleosides was it was a holdover from when with heavily treatment-experienced individuals, and we had a limited armamentarium before the current crop of potent drugs, raltegravir, darunavir, et cetera. And one of the thoughts that people had, physicians and caregivers, was to exploit not just the activity but the resistance mutational interactions. And I think it might be helpful to the press to understand what people were trying to do as far as maintain or resensitize virus by some of the nucleoside combinations.
So if we give some of the medications in combination, particularly tenofovir with emtricitabine, even adding zidovudine, which is AZT, which has been around for many years, that we would force the virus to become more sensitive to tenofovir by promoting the emtricitabine and zidovudine, continuing those medicines, would promote the virus to keep producing this resistance mutation, to several resistance mutations, that would be then more easily treated by tenofovir. So that's the rationale, and try to make that tenofovir as active as possible.
And so, and just to go back, way back in history, not every resistance mutation, of course, is on every genome. And in the AZT monotherapy days, where we see a lot of monotherapy failure, in a couple of studies when the AZT was stopped, there was a bounce up in the plasma RNA a little bit, so there was still some residual activity even though it was basically failing. So, but this is part of the cycle of improvement of fewer pills, better drugs, and making judgments that toxicities and pill burden now are more of a risk than a benefit in this situation, because we can suppress almost everybody. And another question for Karen, just as far as translating the continuous sensitivity score to clinical practice, and how should clinicians look at the genotypes and phenotypes they get back and incorporate treatment history into the package, and think about how they translate your score of greater than 2 into what they're looking at. You know, if they don't see the mutation but the patient was on the treatment before, does that count as 0.5?
Right.
Just to give some practical application to this.
Well, I think anybody can calculate the phenotypic score for their patient because they'll be able to look at the phenotype resistance test, and it was a simple calculation that we did so that if the subject's virus had intermediate susceptibility, we were able to say what percentage of activity did that drug really have just by a simple math calculation. So people can do that, although I'm not sure that people will have time. But I think a lot of clinicians have been comfortable with looking at resistance testing, coming up with the most active medications that they can for the patient in their clinics, and using drugs that have intermediate activity. So I think what our study might help in terms of, translate some of the information from the study is that we used three or four drugs for every patient, and that was not including the nucleosides. So trying to get as active a regimen together that includes 3 medications would be helpful.